Good morning, good afternoon, good evening, and welcome. Thank you for joining us for today's discussion hosted by the Harvard Humanitarian Initiative and the Harvard Chance Studio. Over the past year, the global humanitarian system has undergone a profound disruption. The dismantling of USAID in early 2025 removed one of the central pillars of humanitarian funding and coordination, triggering ripple effects across NGOs, multilateral agencies, health systems, and frontline responders around the world. At a time when humanitarian needs are rising, from conflict and population displacement to climate-driven disasters and health emergencies, the sector has forced to rapidly adapt to a new and uncertain landscape. Today's conversation asks a simple but critical question. What have we learned 1 year later? And where is humanitarian action headed next? We'll explore the consequences of the disruption, how organizations and global institutions are adapting, and what the humanitarian system may look like as we move toward 2026. I'm delighted to be joined today by two exceptional leaders who bring complementary perspectives from the humanitarian field and global health emergency response. Our first speaker is Dr. Michael VanRooyen, founding director of the Harvard Humanitarian Initiative, chair of emergency medicine at Mass General Brigham, and professor of emergency medicine at Harvard Medical School and Harvard T.H. Chan School of Public Health. He has led complex humanitarian operations with various relief organizations in more than 30 countries affected by conflict and disaster, and has worked internationally as a humanitarian and leadership expert with several NGOs. Our second speaker is Mr. Altaf Musani. As of January 2021, Mr. Musani serves as director of the Humanitarian and Disaster Management Department at the World Health Organization headquarters. He's responsible for leading WHO's operations in fragile, conflict-affected, and vulnerable settings, with a focus on managing high-impact diseases and coordinating the Global Health Cluster Partnership. Both speakers have extensive bios, and I invite you to visit the HHI or the studio event web pages to learn more about their backgrounds. So, to set the stage, we are now about 1 year removed from the dismantling of USAID, which for decades played a central role in humanitarian funding and coordination. Mike, as both an emergency physician and someone who has worked on the front lines of disasters and conflict settings for decades, how did these disruptions translate into realities on the ground? What did it mean for clinicians, emergency response teams, and local health systems responding to crisis?
Thank you. And first of all, Irini, Altaf, a pleasure to be doing this presentation with you. We've worked for many, many years with WHO. I have deep respect for the work of the World Health Organization. So it's an honor to be working with you longitudinally and also talking with you today. So thank you for Irini for hosting and Altaf for your work and ongoing work in the field. To your question, just framing, the USAID disruption has created major structural shocks and retrenchment of other organizations as well. So it's not just the retrenchment or the elimination of the vast majority of USAID's budget, but it is also the other countries following suit, which led to a major collapse of the humanitarian sector in many ways. So a large percentage of the aid budget has been essentially eliminated. Now, what does this mean on the ground? Altaf can talk about it as well, but what it's really meant is a very real thinning of any humanitarian effort on the ground. It translated actually very quickly to the reduction in staff, the reduction in facilities, the reduction in funded programs, the elimination or essential elimination of PEPFAR, and a thinning of the humanitarian workforce. And in this case, we see the results of that being less people are treated, less people have access to care, less people have access to preventative services like maternal child health and vaccinations and critical services as well. And so we see large gaps in the humanitarian sector that we'll talk about more specifically in a few minutes.
Thank you. And Altaf, more from a system perspective, WHO sits at the center of coordinating global health emergencies. How did this shift affect the broader architecture of emergency response, particularly coordination among multilateral agencies, NGOs, and national governments?
Irini and Michael, also let me echo my thanks for inviting the World Health Organization to this important conversation. Let me start by saying that the ODA numbers are in. As of 2 weeks ago, we know what those percentages look like and what impact will have on lives and livelihoods. We were projected anywhere from 9 to 17% of a decrease in 2025, and 2026. There's a deep worry that we might find another 25% reduction. This is going to have, as Michael has pointed out, a deep impact, not just now, but going forward in years, in terms of the ability for people to survive, as many of those settings that we're about to describe live hand in mouth in some of these settings. Coupled with this, we know that also global aid resources in 2025 dropped between 30 and 40%. And as Michael pointed out, having direct impact on HIV/AIDS, tuberculosis programs, immunization programs. And it could not come at a worse time in terms of the perfect storm. This is particularly affecting sub-Saharan Africa, where external aid funding exceeds often domestic health funding. And we've recently put out a report which looks at the dependence on external aid. So places like Cox's Bazar, where we run refugee camps as a collective humanitarians. Afghanistan, there's over 98 to 99% reliance on external resources. So you pointed out and you asked, Irini, what have we done as such since then? Literally last year at this time, a core group of humanitarians under the Interagency Standing Committee came together and looked at the wide remit of what is we call people in need. We started 2025 with at least 300 million people in need. We ended the year with 114 million. And then, of course, we walk into 26 as what we call hyper-prioritizing 87 million people. Now, when you start doing the math and start working out the numbers, clearly, from a health perspective, there's going to be roughly 53.3 million people who will not receive health care. And that's a daunting number. That's a scary statistic in terms of where will women, children, the elderly, the disabled, the chronically ill go when Michael has clearly pointed out a number of facilities and services have either been suspended or reduced. As such, the World Health Organization with its partnerships have already codified more than 6,600 facilities that have been directly affected. 2,000 of those have been closed. And we know that this will have a long impact on what I describe in terms of the public health overlay, but also the system to be able to deliver when it is needed most.
You both mentioned this long-term deep impact, and which humanitarian crisis or regions have most clearly exposed the operational gaps created by this disruption? You mentioned some risk to healthcare delivery. So has this increased things like attacks on healthcare facilities and workers, workforce shortages, or interruptions in essential services?
I'll take a start, and I know Altaf will have a lot to say about this one because WHO has really been supporting efforts around understanding attacks on healthcare. I think overall, as he noted, the healthcare system and the overall humanitarian system is far more brittle than we assumed, with a big donor base, a very small donor base that has been, contracted in a significant way. And also now we're facing earmarked funds versus general funds or more flexible funding. What that means in spending across the sector is that some places are going to be winners, or at least not as much losers, and some places will really be ignored. So we know that areas in the Horn of Africa, in Central Africa, et cetera, are going to be underfinanced. They always were, and they're deeply underfinanced now. And there'll be certain areas that earmarked funds will allow us to continue at least some life-saving efforts. I'll comment on the issue of threats to healthcare workers and humanitarian workers, and then I'll turn it over to Altaf, who's, I'm sure, thinking about this all the time. But 2026 is shaping up to be the worst year ever, and we've seen that in stark reality several years ago in Syria, but now we see it, of course, in Gaza, which has been kind of an emblematic case of attacks on healthcare, attacks on healthcare structures, institutions and workers as well, which create a significant chilling effect in the way that we can actually staff and run healthcare facilities around the world. Altaf, you want to comment on that one?
Thanks, Michael. So to put in perspective, the World Health Organization, on the behalf of health systems and healthcare workers all over the world, has a system which tracks various violations to healthcare. And so this healthcare surveillance system called SSA looks at physical destruction of healthcare, detainment of healthcare, and the detention of healthcare workers and its supporting services to be able to provide that critical service in times of need, as you described in certain places. And to give you a figure, since we've started the tracking formally in 2018, although the system was alive before that, we've now verified firsthand more than 9,880 attacks worldwide. On average, before the war in the Middle East, this was about 3 per day. It took 12 days of the war in the Middle East to disrupt healthcare in Lebanon, Iran, and Israel. We've seen significant attacks in those 3 settings, having a direct impact on the functionality of healthcare, and this is critical. So one part of our work is to really document and advocate against healthcare being a target. The other part is to look at the functionality of the system. And I think, Michael, you pointed out, in Gaza, we only have 36 hospitals. And over the last 2+ years, none of the 36 have been fully functional. And there's a range of those issues, primarily because of attacks on healthcare. So, as you pointed out, the attacks on healthcare program is showing the normalization of the violations of international humanitarian law. We as healthcare providers and practitioners are working together to stop healthcare being a target. I was really taken back by the fact that in an internal consultation a month ago, we all recognize the symbols of the Red Cross and the Red Crescent to be neutral, but also to be a haven of peace. Now it's the target. And we see this time and time again. And again, just to come back, before the Middle East, we were looking at 3 per day. We are now up to 4 attacks per day, where healthcare workers, ambulance drivers, patients themselves are either being denied, killed in the line of duty. And this is putting a tremendous strain, as you pointed out, on our ability as a collective to provide healthcare in an equitable and accessible manner.
Thank you. And you both mentioned some chilling statistics. And beyond those statistics and the immediate funding shock, what structural weaknesses in the humanitarian system did this moment reveal that perhaps were already there, but less visible before?
Again, I'll start maybe with an observation and then turn it over to Altaf. Actually, the thing that bothers me the most is this abject disregard for IHL and international humanitarian law. The idea that that civilians are no longer protected in any way. Actually, they're a tool of war rather than being used in war, rather than protected. Healthcare facilities are not protected. And so all of the principles that we hold dear in the humanitarian sector, and a significant one is the idea that of neutrality and allowing civilians and healthcare facilities to be seen as neutral, and really truly understanding that violations of that are violations of international humanitarian law, but they happen daily in many areas around the world, such that it has become normalized. And that is something that even more than the funding cuts. So we see the retraction of aid around the world, but even more than that is actually the disregard for humanity, the disregard for neutrality, and the disregard of principles and laws such as IHL.
Yeah, Michael, maybe just to add on a couple to that. So when you take the financing mechanisms and the limitations of such, when you add in that space that you described that constantly shrinks, and then you increase that vulnerability, here's what we've started to see. We know, as you pointed out in the beginning, that our NGO partners and local health providers have less coverage as well as less access. So For example, we know that 14 million children around the world in these humanitarian settings are dependent on therapeutic feeding or admissions into what we call SAM centers. Their ability to access severe acute malnutrition support is at risk. We know that, as you pointed out in the beginning, maternal and child health is at great risk. There was a tremendous dependence on external support by a range of donors to be able to really practically enable women to deliver safely, as well as the newborns to come into this life with the necessary care, be it neonatal care and postpartum care. And that is all at risk. We know that gender-based violence has always been weaponized, and increasingly, but those survivors need clinical support. This goes on and on. Our ability to constantly vaccinate children. When we look at the situation over a 2-year period, there were only 3 distinct windows for our ability to try and vaccinate children who need life-saving vaccines to survive. And so all this is coming together, as I pointed out, the chronically ill, the elderly, the women, the children, the trauma injured, all depend on the system. And let me share a metric with you. In 2025 alone, our systems have recorded over 110,000 hits, changes to those systems. That looks at functionality, and we only codify functionality in 3 parts. Either you're fully functional, you're not functional, or partially functional. As healthcare practitioners, we would attest that there's nothing else but being fully functional. And as I pointed out, no hospital in Gaza has been ever fully functional in the last 2+ years in Gaza. We know that there's been a 6-fold increase in non-operational status of health facilities around the world. This includes Sudan, this includes Myanmar, this includes Haiti, and it doesn't end there. We, as you pointed out with the attacks program, surveillance directors, laboratories, institutes of Pasteur that are being attacked, are all really having a tremendous impact on the ability of the system to provide in a neutral, independent way those services that are critical to life-saving, but also life-sustaining. And that's the key concern at this stage, with the lack of funding, the shrinking space, and of course that need, that real need to be able to overlay that public health risk in many of these settings is being challenged.
Thank you. Well, let's shift now from the immediate shock to where the system stands today, and maybe first with the WHO operational response. So WHO's Health Emergencies Program often serves as a backbone for coordination during crisis. Over the past year, how has WHO adapted operationally, whether through new partnerships, financing mechanisms, internal structural changes, or changes in how emergency health interventions are delivered?
Thanks, Irini. I think an important question, because the World Health Organization has also been challenged as the global health leader in this environment. And I think just to start with the fact that when we look at risk, we look at the threats and risks to infectious disease, natural hazards, as well as armed conflict. And just to share with you that in 2025 alone, the World Health Organization, through its ministries or through its partners, have had to respond to what we call 37 graded events. These are a series of infectious disease outbreaks, making sure that service is available in places like Gaza and South Sudan, as well as responding to earthquakes and natural hazards. So our workforce has shrunk due to the prioritization exercise that we've just overgone. Like many other United Nations agencies, that core capability of our workforce, our supply chains, and our ability to monitor that risk is all constricting at a rapid rate. And I think one of our challenges is to make sure that that is safeguarded. It has had a deep impact, as you pointed out, on our country operations. We're present around the world in at least 118 countries. And of course, our regional office provide a backbone that where we're not present, there is always that availability of public health advice. But our operations, our ability to keep standing up, not just engagement at the capital level, but in the case of South Sudan, we have 11 sub-offices. In the case of Afghanistan, we have 8 to 9 sub-offices, and this requires us to be field present. Now, on a positive note, the system itself, through what we call the humanitarian reset, is trying to prioritize, and I mentioned this earlier. We've walked away from 72 countries in the global humanitarian overview to prioritize 50 and then hyper-prioritize a subset and this is 87 million people who really need support. These could be individuals who've been classified in IPC 4 and 5 situations. These could be individuals who are in what we call severity score 4 or 5, meaning they really depend on humanitarian assistance. And our ability to manage that scale and scope is tremendously at risk. We continue to use a risk management framework to be able to decide what events we engage in. And I think as a fallout to several drivers of change, so I mentioned the humanitarian reset, there is the United Nations 80 initiative, and then there's also the global health architecture, which is 3 drivers of change, at least on the public health landscape, is to make sure, one, member states hold the responsibility but accountability to serve their people. 2, as and when risks and threats go beyond member states' capability, how do we as a system plug holes? And I want to be clear about this. We're not here to replace governments or partners. As and when asked, we plug those critical holes. And thirdly, is to really share and understand what that risk looks like and how does that affect communities, how does it affect neighborhoods, how does it affect regions, and we do look at that wider health security lens to be able to understand whether it's an epidemic, whether it's a pandemic, whether it's hunger crisis, whether it's a displacement issue, whether it's refugees, how does that interplay in terms of health-seeking behavior and public health needs?
Thank you, Altaf. And Mike, through the Harvard Humanitarian Initiative, we work closely with NGOs, UN agencies, researchers, and humanitarian practitioners worldwide. How have humanitarian organizations adapted over the past year?
Yeah, so well, and first was the I guess the acute phase, which means the disruption of funding. So many organizations saw anywhere from 30 to 40% of their budgets cut or more. Probably 80% of organizations have had budgetary disruptions to a significant degree, and 80, 90 organizations have had to suspend activities in one or more countries around the world. So we've seen a major contraction of the humanitarian sector from NGOs, including staff termination, closing in offices, constricting activities, even while they maintain a country presence. The next phase of that is normalization and then trying to understand it. So OCHA, for example, the Office of the Coordination of Humanitarian Affairs, is as Altaf mentioned, embarking on the humanitarian reset. The humanitarian reset really looks at first defining or prioritizing and hyper-prioritizing certain needs. What that actually means then is deprioritizing other needs, such that funding is just not going to get to some areas in the world and some populations. The next one is leaner delivery. So delivery that is leaner, faster, and more efficient. That is easier said than done, particularly in UN agencies that have a considerable bureaucratic structure. So there's a lot of work to do to see if the organizations can be leaner. One of the other pillars is devolving, and I think we're going to talk about this, which is essentially shifting to localization. Now, those of us in the humanitarian sector, we talk about localization as a good thing generally, and we all believe that increasing local capacity is important and necessary and good, and have for many years actually embarked on that. The problem is constricting funding and increasing localization don't match. So what that just means is that we're pushing the local agenda or many more responsibilities to local actors, and the risks for that matter, without appropriate funding and without appropriate support for access. And then finally, the last part of the humanitarian reset is defending or protecting humanitarian principles that, as we mentioned before, are really under threat. So in summary, I see that the NGOs are all individually adapting to a much more constrained environment. And the UN agencies also are contracting, reorganizing, and in the best circumstances, becoming more efficient. In the worst circumstances, probably considerably dropping off services.
Thank you. And I would like to go back to what Altaf mentioned about the millions of people left behind, those in need. So we know that WHO plays a central role in monitoring access and coverage to healthcare in a range of fragile and conflict settings. And WHO has estimated, with the hyper-prioritization appeal that you mentioned, that the humanitarian community will focus on saving the lives of 87 million people in 50 countries. In this new funding and coordination environment, have health services and public health programming been affected, and how confident are you that the current fragile system will be able to deliver to the most in need?
So maybe I'll jump in here before Michael does. So I think it's important to put it in perspective. With those numbers that you cited, Irini, we've also estimated that 53.3 million people will not have health care. These are individuals in places like Myanmar, Haiti, South Sudan, Ukraine. And the challenge is what happens next. And I think, Michael, you were trying to address this in terms of going forward. And this is a responsibility on us collectively to understand where will people seek health care. And to such, we're actually having a conversation in the next couple of days with partners that look at health information systems to be able to track where people are seeking healthcare. We know often in places that have been described that both births and deaths take place at the community level, and how they get captured and then come back into the system. There's always a gap in understanding the severity and scope of both mortality and morbidity. But it's to say that we're now in a new phase, as Michael pointed out, is now that reset has been understood as best, with less money, more needs, and of course handing responsibilities back to government, working with them to make sure that they have the tools and the technical assistance needed. I think to point out that the two potential solutions associated with this going forward is something that, as Michael has said, has been kicking around for a while, is what we call area-based coordination and localization. Between the two of those, at least we feel that the architecture that the IAC, or the Interagency Standing Committee, represents may not need to be present both in capital and what we call deep field, where the ABC approach, area-based coordination, will lend a greater responsibility and integration of services, so that way we don't just look at health, water and sanitation, shelter, and protections in isolation. We've done a really good job, and I probably should have started off with this earlier. Michael, as humanitarians, we have for decades constantly been under change and scrutiny for all the right reasons. I think because we represent a system that serves or aims to serve humanity, there is a greater sense of oversight in terms of where we work and how we work, and making sure that we have efficiencies built into the system. I think we've done a relatively good job to constantly reform. We've had several reformation periods, starting off in 2005 with the birth of clusters. And again, without getting into nomenclature, the purpose of those clusters is to make sure avoid duplication and have a standardized approach. Within the health cluster, there are about 1,500 cluster partners worldwide. 2/3 of them are local, and I see that as part of us looking towards the future and solutions, local partners. And to give you a practical example, we know that the International Federation of the Red Cross Red Crescent have those local trust currencies built in. And in Iran, there are 2 million volunteers working for the Iranian Red Crescent. They're the ones who are deep field. They're the ones responding to outbreaks. They're the ones who are responding to trauma and injury right now. And I think, we've got an infrastructure that we need to tap into and utilize more. We've got to devolve, as Michael has said. We focus on the 4 Ds. And then I think we need to take some protected space beyond the localization and the ABC agenda, is to rethink what Humanitarian 2.0 looks like. As such, I'm aware that the Lancet Commission series will be coming out with a report to help shape that thinking. We head into the World Health Assembly within less than 60 days to really debate what does the public health landscape look like. And I think that's where we are right now, is to participate actively in that conversation, informed, evidence-based. And I think, both of us recognize that post-pandemic, there's a lot of misinformation, disinformation out there. Whether it's accessing healthcare, whether it's the onset of a true outbreak, whether it's the diagnostics and the tools to treat both patients and outbreaks alike, to be able to manage that scale and scope. So I think all this to say that conversations are constant, reform is a constant, and I think part of the solutions, even beyond area-based coordination and localization, is to look at our development partners And I see this as another pivotal point where we often see in places called Bulape in the Democratic Republic of Congo, or in outside of Port-au-Prince, we don't necessarily see the formalization and the activation of our development partners. We're a dual-mandate agency, so we're present there. But these are the IFIs. These are the banks and the development partners. And just to share with you a positive example. In Afghanistan, we know that more than 2 decades ago, the highest maternal and child mortalities were being recorded worldwide, meaning that women were dying at a rate that was exponential, and therefore child mortality was also alarming. Investment over 20 years with banks, humanitarians, and the Afghan authorities in the lead, the community at large managed to cut those rates in half. I mean, that's remarkable. That's outstanding. That's what we want to see as public health professionals. Now, a lot of that, again, is at risk because those resources, those coordination mechanisms, and that political will is at question. And I think I'm often accused of presenting too much doom and gloom given the world we work in. But I think it's really important to also showcase where it does work and how do we keep making those investments.
Thank you. And you both mentioned localization. So are we seeing a shift towards more locally led preparedness and response, including health workforce development, or are the gaps widening and national, community, and local organizations are just simply asked to shoulder more responsibility without adequate resources?
And Altaf mentioned this well, I think both, right? And so I think what we see is for many years, the partnerships that have been growing, building local capacity, building and investing into local organizations that can actually do this. It's been a practical concern because many areas are somewhat inaccessible, actually. And frankly, international actors are inefficient, right? And so the idea of building local capacity has been a theme for many years. And over the last several years, just the term localization as a sort of a planned movement actually has been discussed repeatedly and as a strategy. It's of course important and it of course needs to advance. The problem, of course, is that we're in the middle of what Council on Foreign Relations says, the great aid recession, right? We've contracted so much that now we're placing the responsibility on local organizations without the financing, without the funding, and without the capacity building. And so that is a major challenge for organizations who have to do far more with far less in far more dangerous and challenging circumstances. And so the gaps in coverage remain and are widening, and we will have to figure out how to advance localization as well. Now, Altaf mentioned the issue around the humanitarian architecture, and the humanitarian architecture being the way that the aid world has really evolved over many years. And I also believe that the humanitarian aid world that works in the most complicated situations, in the most complicated areas, has evolved structurally and considerably over the course of many years. And this will be another evolutionary period. And we're just going to have to see what happens with, say, the cluster system, right? So the cluster system was an adaptation to a poorly coordinated system. What happens to the cluster system in the next year or two or more is going to be really interesting because there are elements to that are actually crucial. The coordination of humanitarian services is crucial and needs to continue. But the mechanism by which we do that is unclear and maybe has to evolve. That will also carry down to everything from prioritization, like we see in SPHERE standards, for example. SPHERE grew out of very clear initial sector-based assistance and really grew to include many other areas in education, in preservation of rights and work and a variety of issues. I think we're not going to see things like SPHERE go away, but we'll probably have to see, as Altaf mentioned, a hyper prioritization, not only in the populations we serve, but in the kind of services that we provide.
So, Irini, I would just come in here. Lebanon, which we're seeing unfold again since 2024 and now, it is national NGOs, civil society, and local health workers that are providing the bulk of assistance to IDPs and to those that are affected by bombs and bullets. So that is a very good case in point whereby you may not need, as Michael pointed out, that entire architecture to come in and substitute or complement. And I want to be careful as not to take over. So there are a number of countries and or settings that represent this. Myanmar, another case in point. We talk about cross-border, cross-line. You know, the trust currency with the community is built over time. And that's where civil society, community-based organizations, and national NGOs will always hold that trust of the community. And I think we've said this time and time again, pandemics and epidemics start and end with communities. Those that are the first responders are the individuals from the Red Cross and Red Crescent Society or the local providers. And I think we have to be careful that it's not a light switch moment that we just divert all our resources that way and our attention that way. We have to build that capacity and culture. And I think the two examples I cited are where that it's mature enough that we know that between 2024 and 2026 in Lebanon, our appeal needs are different. Certainly the needs increase, but I think those capacities, as long as sustained, local, they definitely have different cost factors associated with them. We need to work with them to build the technical base, but also understand how to manage large sums of money. And I think that certainly some of the challenges associated with the localization is when we talk a wide spread of needs. So if you think about Darfur, the 3 Darfur states, you know, there is an inherent expectation of the international community is to look at not only the scale and severity of this, but to be able to provide assistance framework to all those in need. And I think that issue of scalability and how do we tackle that with several partners, a multitude of partners. Remember, Michael and I have worked in these environments. You go into them and there's a wide range of actors coming from what we've seen most recently in South Sudan and Gaza, private sector having a different agenda, or in the case of Lebanon and in Myanmar, where it's the national societies or local providers who have the ability, or in other places where the international humanitarian community needs to come in and substitute. And I think one thing beyond the financing, which we all need to share and continue to uphold, is the humanitarian principles. And that's something between 2025 and 26 we're deeply worried about with the examples of Gaza and South Sudan. We must and should and will always remain principled, because when we erode those principles, that puts those we aim to serve, and we call this the AAP, the Accountability Agenda for Affected Populations, is what is at risk. And so it's interesting, we as health professionals, we have the international humanitarian law that guides us through humanitarian principles. But I think as health professionals, we have medical ethics and the public health imperative, which also drives us to make sure we do no harm. And I think these are really extremely challenging environments right now. It's catastrophic in many of these places. We had, as an example, in 2023, 5 declared system-wide activations. So just to break that down, that means in 5 distinctive locations, that system that Michael describes had to be activated in order to address needs and try and bring some alleviation to the problem. That's unprecedented. I mean, in my career of 2 decades plus, we've never seen 5 within a calendar year being activated. The worry is, if we look around the horizon, and I know we'll get to this, is it's certainly armed conflict seems to be the flavor of the day.
Thank you. And looking ahead, both of you mentioned a little bit about how the humanitarian system might evolve in the future from here. So what specific changes you think are needed in the global architecture for emergency response at the UN level, in governance, coordination, or financing, to ensure that the system remains functional in the absence of traditional pillars like USAID?
And this will be Altaf's sweet spot, so I'll be very brief and turn it over to him, because I think he's thinking of this every day. But I think some of the major principles are, first, the structure of funding, how organizations are going to fill the gap, because we can't really depend on USAID coming back, or even US funding coming back to the degree to which it was. And so we're going to have a more diversified funding series of sources that lend itself to pooled funding. We were all sort of pleased to see that the $2 billion that the U.S. appointed, it largely went to OCHA and then to some areas. But some of the challenges with that is that it was earmarked to certain areas around the world as well. And it's really intended to push humanitarian aid out in a way that is, again, hyper prioritized. So, and frankly, the $2 billion was a fraction of what either is needed and was previously provided. So while we were happy to see that, it is a small portion of what was given before and what needs to be given. So I think pooled funding is a big issue that we need to see and develop as we go. I think as Altaf mentioned, and expanding localization and promoting localization, I think is going to be crucial and critical as well. And then, as much as possible, maintaining the ability to provide needs-based humanitarian assistance to countries that are going to be left behind. And so those, for many years, we take it for granted that we as a humanitarian sector were able to actually look at needs and, draw funds and address humanitarian needs globally without having the donors necessarily prioritize aid. I think, and I worry that we're heading into an era where donors will prioritize regions, countries, or populations that will be recipients. And it won't be needs-based alone. But Altaf, I'd love to get your thoughts.
Sure. So I think clearly financing is at the heart of a lot of these conversations. And I think you and I, Michael, agree that, for the decades plus, it's those humanitarian donors, it's the capitals, it's public money that has brought us here today. And I think there's a deep amount of respect to major donors, but minor donors who have created a diverse landscape to a certain degree, but then become thematic or geographic interested in other areas. And I think the Afghanistan example, just to unpack it again, it was USAID, it was the European Commission, it was the World Bank, and it was the Afghan government. I mean, there was great alignment on that. We need to see more of that. And I think there are a few other examples. So just on the financing, absolutely, there needs to be a revisit of the humanitarian financing model. One, we need to make those inroads with our IFIs. We have a few interesting examples where the International Development Assistance Window, this is managed by the World Bank, called IDA, in Yemen, not so much right now in the case in point, but prior to 2025, IDA funding was propping the system. So a good complementarity between humanitarians and development partners who come together and say, let's look at system resilience. When you build systems, and then you enable people to reduce the barriers of care, we're able to get really good outcomes. So Yemen is a good example. We started to see that in South Sudan. We started to see that in Sudan. We started to see that a bit in Ethiopia as well as Iraq. So all this to say that there's a tremendous amount of dynamic change in the financing models. But to what you and I both know is they've always been siloed. Humanitarian bucket on one side, development on the other, and we need. And I don't even want to reference the nexus, having just did, but we need to break that divide and say that it's financing to address a wide spectrum of needs. So I think there's that. Connected to that is private sector. We've often scratched at the surface as to what really is the private sector engagement. There are certainly a tremendous amount of philanthropies that have opened the world, foundations have opened the world, but we have not been able to truly convince the private economic sector to understand why this is an investment. And I think there are many things that keep me awake at night, partly new threats around the horizon, but that financing where we keep saying that there's less money. There's actually a lot of money out in the world right now. And Tom Fletcher in the last 48 hours talked about, the billions of dollars to manage the war machinery as opposed to the billions of dollars to save lives. And it's not a lot when you look at, as you pointed out, the percentages and the proportions. So I think we need to continue to invest in humanity, but those financing models need to be sustainable so that humanitarians are not finding themselves in the DRC, in Somalia, in Haiti for 60 years, propping up, setting up durable solutions, because that's not what you want humanitarians to do. That is better positioned for some of our wider aid and development initiatives. Then I think the second point, and you mentioned this, if we look at the risk of armed conflict continuing to rise, so ICRC puts out that there's some roughly 150 armed conflicts that are active in the world. That was prior to the Middle East situation. that need continues to escalate. And the question is, well, with our capacities as a collective humanitarian community being eroded, who will be the firefighters? Well, here again, we both pointed out, it's the communities, it's the local partners. They're going to need that coverage, space, and financing to do what they do best. And we've seen this, again, in the case of Lebanon, with the recent ceasefire in effect, we know that 1 million people migrated to central Lebanon and north. And now with the ceasefire in place, we've seen, again, that massive amount of redisplacement. So the resilience of people is something that we shouldn't underestimate. These are individuals who see famine, disease, displacement, often get displaced not one time, but up to 7 times in places like Darfur and Gaza. And their resilience as people is remarkable. And I think that's something that we need to better understand. And I'll end with the fact that, our traditional models of establishing response paradigms also needs to evolve, taking into consideration innovation. You mentioned the word efficiencies. I think there's a cost factor for a United Nations agency and there's a cost factor for a local partner. Those don't necessarily square and may not. But the fact that when we need to go to scale and look at nationwide or a wide geographic area, the Sudan is tremendous in terms of geographic coverage the humanitarians need to cover, and the Darfur states being one side, Kassala being another, and then the proximity to South Sudan. Ultimately, beyond innovation and financing models, we need some of these conflicts to end. And I think my Director General has been very clear about this. He often says there's no health without peace and there's no peace without health. If we can resolve some of these conflicts and end some of these conflicts, I think we give people and humanity a chance, of which, if we look at DRC and Somalia and Haiti and Myanmar, these are conflicts that have been 6 decades in the running. And, as you pointed out, there's certainly less money, but there's definitely more need.
And just to highlight a couple of things you said, I think that's so important, is the what's so needed is the durable solution of peace, and the idea that development really has to take. I mean, nobody knows more than the WHO, which has certainly a humanitarian component, but also has deep development roots, right? And so the ability to actually bridge those, that the relief to development sort of approach, I think, is critical. And you can't. War is the great de-developer. You can't actually do that or accomplish those aims without peace. I will say the one note of, I'm generally optimistic about the future of the aid sector, since, we're still alive and we're still doing it. I will say that I'm not optimistic about the role of the private sector. For many years, we've talked about the meaningful role of the private sector but it's generally all incentives based. And generally, I think, I would worry that we can't depend on it. What we can depend on, actually, hopefully, is stepping up of the nations that can fund this and have funded it to sort of refund it in the future, and also accomplish all the aims that you described. I just worry that the private sector is just not going to be the answer for us.
And Mike, you mentioned that the private sector might not be the answer, but to both of you, as we look forward to the next few years, what could be some answers or some the opportunities for the humanitarian system to emerge stronger from this disruption?
Well, I think anytime there's a major organizational disruption, and this is, again, a profound disruption, but, in the biggest sense, the needs persist. The organizations that are fulfilling those needs will persist. The organizations that have built their sort of, for generations, have supplied humanitarian needs and have come together to provide humanitarian needs will exist as well. We just hope that in the future we can actually become more efficient. We can become more targeted. We can actually invest much more into developmental and preventative services as well, such that peace is required, and then look to make the argument to nations and national budgets that actually the investment in peace and stability, and also in development, and ultimately in the humanitarian sector, is just good business.
So I would pick up where Michael left off there, and I think you said it, the 3 Ps, prevention, preparedness, and peace. I mean, that's the opportunity in front of us. It costs much more in terms of millions of dollars to establish a response paradigm as opposed to preventing it in the first place. And so again, hazard specific or threat specific, we're not preventing the next earthquake here, but certainly we've built mitigation measures around different risks and threats. What I'm struck by is Hurricane Melissa in the Caribbean, and through the Safe Hospital Initiative, which we look at, the structural integrity and the functionality of a hospital, we're able to make sure that it can withstand a certain category of hurricane. Of course, these are small snippets of examples all over the world. We're using a tool to understand hospital safety and integrity. That certainly is another first opportunity. But I think outside of the peace agenda, the prevention and the preparedness, we often don't have the luxury of time to invest in what may become a potential future armed conflict or the natural hazard or the epidemic around the horizon. But what Michael and I both know as a collective, as well as yourself, Irini, we've got a tremendous swath of lessons that we've learned from COVID-19, from the influenza pandemic, from responding to armed conflict. I think it's the application of those lessons, and it's the sustainability within communities and governments that hold the responsibility and accountability for this. The news cycle is 24 hours, and we just lap on the next problem. And I think both Michael and I have showed, having been at this for a while, there's a tremendous amount of lessons. There's a tremendous amount of goodwill out there. The challenge is to have these kind of conversations. And I think today's conversation is such, you will certainly influence your community of practice. I hope to take back lessons with mine and make sure that there is a set of common messages. I think with misinformation, disinformation, there's a dilution of the message, there's a pollution of the message, and I think we as practitioners need to continue to uphold that standard and continue to portray that there is hope, there are financing models, there are life-saving paradigms which are efficient and have worked. I think the challenge is we just have to deal with a lot more. And this is that, famous, do you do more with less or you just do less? And I think we're going to be triaging a tremendous amount, both now and before the end of this year. And let's not forget that while we're dealing with fires burning in certain parts of the world, there are still fires burning in other parts of the world. You have the complementarity of what we call contagion, climate, and displacement happening in many parts of the world. We managed to, as a collective, roll back famine and the implications of famine in parts of the Horn of Africa. As we speak now, we've just regraded that as an alert and risk in terms of children who may die without having access to measles, the risk of cholera, the risk of malnutrition. And I think that's where we find ourselves in a very cyclical pattern. How do we break out of that cycle? And the financing models is part of it. Innovation is part of it. But my worry is that we also need to ensure that leadership understands why we do this and why it's important for nations. You'd be surprised. I often have conversations here at Geneva level speaking to parliamentarians, and it's a challenge when you have domestic needs, global needs, regional needs. How do you justify that? And I think leadership needs to understand that this is a good investment. The more we invest in humanity, we can reduce displacement, we can reduce these disease patterns, we can reduce hunger. But it requires, as you pointed out, Michael, that sustained investment with an exit strategy.
Well, this leads me to my last couple of closing questions. So we are here at Harvard. So many students and young professionals are watching this field evolve in real time. What would you say to the next generation of humanitarian and global health leaders about the role they can play in shaping the future?
Yeah, as someone who actively teaches students, and we have students that are undergrad and graduate and PhD, as well as, professionals across the globe, one thing that I would say is that it remains as important as it always was. If you're looking for a career that is important and your labor, which is one of the most valuable things you can give, to lend that or to give your labor to something that is important. This is inherently important. Secondly, we have no, I guess, option except to be optimistic. Like we're in it to change it. And so Altaf and me and scores and thousands of other people in the sector, we're in it because we believe that actually we can make a difference, and we collectively can take responsibility for these really challenging, really difficult problems that are not going away. So what I'd say to a student is expect it to not be easy. Expect it that your role will maybe be, instead of sliding into the humanitarian sector, actually changing it and reforming it and trying to see what it's going to be in the future. But realizing that it inherently is important, inherently it can't go away, and inherently it's going to be, as it always was, challenging, difficult, rewarding, life-saving, and critical. Frankly, I'd say in a really optimistic way, what else do you want from a career? Right. What a phenomenal way to spend your career to save lives around the world. So I'll just leave it at a rather Pollyannish and optimistic tone. But it's a wonderful opportunity to do something really big, really important, and really difficult. But it needs to be done.
Yeah. So maybe I'll start with that, Michael. We both don't underestimate how difficult it is. It's a bad time to be a healthcare worker, a humanitarian, and humanity in general, because we're all under attack. Beyond the attacks that we've recorded, we know that more humanitarians and healthcare workers have been killed in the last 3 years than they have in the last 30 years. So I think it's important to understand that the environment that we work in is going to be extreme risk and hardship. So at least make sure that it's that realism has set in. A lot of our staff working in those environments are detained and are working under extreme conditions. So it's really, really important. And I think, HHI does run a simulation exercise every year, to give a flavor of how complicated some of those environments get, where you have military and security and donors and those vulnerable and, access constraints and visa constraints. The list is endless. So I think it's important that we share that reality with the future. Two, just this past Monday, we had Dr. Izzedine in the building. And, he's written this book, I Shall Not Hate. So he's been nominated 5 times for the Nobel Peace Prize. He's a Palestinian doctor. And that's, it humbled me, the fact that he, as a Palestinian doctor, will continue to treat everybody. So he's treated IDF soldiers, he's treated Palestinians. And what he said, and these are his words, is that we live in a world today where everything is weaponized, politicized, militarized, those are marginalized, and the danger is everything is becoming normalized. So we have to rage against that normalization. We cannot bend medical ethics. We cannot tarnish the public health lens. And we certainly cannot debate the humanitarian principles, of which are all in question in so many parts of the world. And so I think that realism that needs to set in, that drive to be able to say we stand for humanity. And I think this is where being a public health professional is particularly exciting, because we have those different elements that force us to do good, but also prevent us from doing harm. And I think you and I have both seen it in the last 2 decades, that public health injection of resources and public health schools and thinking is shrinking. We need to readjust that balance, where we're using either a public health lens or medical care to those who need it most as a point of conversation. And I think this is where it becomes comfortable, because like you, I'm a humanitarian, I'm not a politician. But I think humanitarians need to be put into spaces where some of those difficult conversations are being had, and point to the fact that, as you rightly pointed out, we can save lives, we can sustain lives. But we want to be careful is that we're not promoting the fact that we'll save lives for them to be killed, hurt, detained tomorrow. And I think this gets really complicated when you look at, a cholera outbreak, which you and I know best. it requires clean water. It requires a potential vaccination. It requires reducing the barriers to care, and it requires the clinicians to have presence in a diarrheal treatment center. And we know that co-infection, comorbidity are an issue. So I think that we have the knowledge, we have the science, we have the goodwill. I think we need to be able to fight for that space. And you know, as I do, as best, that space is constantly evolving. We find that often that space opens up and we run in and jump to make sure that stays open. But the worry is it's really closing down. And I think as a collective, and you think about this, health associations, doctors associations, paramedic associations, public health associations, anybody who has an interest in health or humanity or humanitarianism, we need to rally around some of these things. And I often find that people don't necessarily share the same understanding that we do in terms of the trends. If we look at the epidemiology of injury or the epidemiology of humanitarian action, as you said, it's changed a lot. And I think we need to fight for that space. And I think, as Dr. Izzedine pointed out, we have to have that hope. We cannot let that hope die. And we've seen this time and time again. You know, in Gaza, it's that hope that keeps Palestinians moving forward. It is that hope in places, if you're in, you know, Camp Tawila, to be able to seek healthcare or seek protection. And I think that is another entry point, is health cannot be seen in isolation. We need to make better efforts to bridge these silos between protection, food, water, shelter, and health. My worry is that health, because it's not a single commodity, it's not a single service, and it's not a single system, you and I know best, we want the entire system to be present in a lot of these settings. I think to that extent, you know, like I said, innovative financing and innovation, that will drive change, and that's what we hope for.
You both mentioned resilience, optimism, and I would like to end this conversation with a note of hope. If you can both give me one brief comment on what makes you optimistic despite this disruption and uncertainty. Mike?
Altaf, you're on a roll. Go ahead.
So I've obviously, you know, so in my career, I've actually run and established programs. And when you interface with children, when you interface with their mothers, or their grandmothers who've brought them to the facility, it is so heartwarming to see that you can do something, right? And you know, this is it's something within us as human beings. Because again, you know, without oversighting Professor Izzedine here, you know, we all bleed red, and we all share a common goal on this planet. And I think it's so heartwarming that when you see that resilience of children or their mothers or the chronically ill coming to the center and breathing a sigh of relief. It's humbling. It's that humble approach, that the fact that we can do good and we should do good. That's what keeps me alive and pushing this institution to do more. And like you, I wish that there was a sufficient amount of resources for us to do more and reach all those, as you pointed out, Irini, who need us. So I think, you know, that's what gives me hope is that smile, that touch. I was fortunate enough when the situations changed in Afghanistan, the Director General invited me to accompany him to meet the Taliban for the very first time. And it was, you know, I started my career in Afghanistan, and it was a very different look and feel. But the Afghan people were the same. And when you interact with them, when you engage in a conversation through an interpreter or without an interpreter, that's what keeps many of us going, to say that we know we're on this important path to do better. And I know we can make a difference. I'll leave it with that before I get a bit sobby.
No, and I'll come in and thank you, because I think you've said it so well. And that, you know, I've been in the sector for over 30 years, and it's always been a fight. It's always been a battle. It's always been challenging. It's always been difficult. And yet it's always been profoundly rewarding for all the reasons that Altaf said. We know that this is inherently important. The work is not going away. The needs are not going away. And to give your life and your work and your labor to something that is actually inherently incredibly important humanity and preserving humanity and preserving human dignity is the single thing that if you at the end of a career can reflect on, I think it's a gift. So I would say that the aid sector needs a lot of adaptation, a lot of change, and a lot of sort of reorganization, and we have to do and continue to do better to serve the people that we need to serve. But my hope is that our enthusiasm, our creativity, our innovation can actually carry the sector into its next generation.
Thank you to our speakers and to everyone who joined us today. Humanitarian action has many times evolved through moments of disruption. However, the current challenges are very significant. Conversations like this can help us to collectively think how to manage this transitional period intentionally with equity, evidence, and collaboration at its core. Thank you.